Hello, neurophiles. Dr. Rybinnik here. For this topic, I enlisted the help of a friend.
So give a warm welcome to the critical care neurologist extraordinaire, the chief encephalopathist, Dr. Ram, think outside the box, Gowda.
Take it away, Ram.
Hello, friends. I'm Ram Gowda, and I'm one of the attending neurointensivists here at Rutgers Robert Wood Johnson Medical School. So today's talk is about coma. So first, we're going to review the early management of patients with the acute confusional state. Next, we'll discuss the neuroanatomy of alertness, the coma exam, and the three main herniation syndromes. We're also going to learn how to address intracranial pressure crises and how to manage cerebral edema. Next, we'll go over some of the choice pathologies that can cause coma. And finally, we'll conclude with a discussion of outcomes for patients in a coma and review the steps for brain death declaration. So let's start with the case. So we have a 55-year-old woman, previously healthy. She developed 3 days of diffuse headaches and was found by her family on the floor of her kitchen, lethargic and vomiting. So called EMS. Initially, the patient was able to converse, but quickly progressed to unresponsiveness and had to be intubated by EMS after their arrival. There wasn't any shaking, no incontinence, there wasn't any arrhythmia or significant trauma noted. On the initial evaluation in the ED, vital signs are normal, obtunded, grimacing to sternal rub. She has some withdrawal to pain on the right side, but not on the left. The pupils are responsive to light, but uneven. The right pupil is larger than the left pupil. The right eye also seems to be slightly deviated outward. She has a cough and gag reflex, but there's also extensor posturing on the left side. The patient was already intubated in the field by EMS for airway protection, and she's currently hemodynamically stable in the ED. So now that that's taken care of, what's the initial approach to the management of the acute confusional state? This is clearly a neurologic emergency. Treat first and ask questions later. That's a little hyperbolic since you're obviously still continuing your assessment. But the guiding principle here is that you shouldn't wait for a definitive diagnosis before initiating treatment for dangerous diseases. So let's review the general approach to a patient in acute confusional state. History is still key. Doesn't matter if the patient's comatose. You might need to make some phone calls since the patient's usually unable to help you here, but you still have to gather history. The time last known at baseline is extremely important when you're considering eligibility for any kind of stroke interventions. And the description of the actual event, past medical history, medications, toxic exposures, any previous episodes, all of these can give you a clue to pathology.
Trauma's out of the picture. Could still be infection.
Or neurological or genetic. We need a better history.
If the symptom onset is within 24 hours, you should really consider activating a stroke code, especially if you see focal neurologic deficits. You really don't want to miss a treatable ischemic lesion. Next, ABCs. This patient is no different than any other emergent patient. Make sure that airway, breathing, and circulation are all stabilized. If they're unstable, your first priority is intubation and hemodynamic support. Luckily, the EMS already took care of that in our case. After that, let's work on IV access, cardiac monitoring, any respiratory support such as supplemental oxygen, send labs, and if it's a trauma patient, immobilize the C-spine. So why do we send all these labs? Well, toxic and metabolic causes for the acute confusional state are far more common than other causes. So first things first, let's fix any electrolyte issues, especially sodium and calcium. Consider sepsis, vitamin deficiencies, especially thiamine, and any kind of poisoning. If the cause of encephalopathy is known, let's say a person was found next to a bottle of benzodiazepines, then we can address it at this point. So thiamine plus glucose for suspected Wernicke's encephalopathy, flumazenil for benzodiazepine, naloxone for opioid overdose. I'm sure you've read a ton about the opioid crisis, and these people are showing up in your ED, so think about it. But don't forget, opiates aren't the only thing that they're taking. All of these have been covered in the Toxidromes lecture, so refer to that for more information. Next, do a rapid neurologic evaluation. In the real world, of course, you're doing this in parallel with getting your IV access, hooking up monitors, sending labs. All these things are happening at the same time. So what's the goal of the neuroexam? Really, it's to look for localizing signs, any focal findings that point to a focal causative lesion in the brain, as opposed to a diffuse disease process. You can't spell neuroexam without neuroanatomy, so let's take it back a bit to some basics. Shown here is a sagittal cut through the midline, where you can see all of the important components of the ascending reticular activating system that keeps you awake. So we are talking about the pons, midbrain, thalamus, hypothalamus, and cerebral cortices. It follows that there are essentially 4 kinds of lesions that cause coma: dorsolateral pons, paramedian midbrain, diencephalic, and bihemispheric. So for example, if the straight sinus is thrombosed, the diencephalon, the thalamus, will become ischemic, causing coma. Or if the basilar artery is occluded, the pons and midbrain can be damaged, coma again. Generalized tonic-clonic seizure, bilateral cortices are inactivated, coma. You get the point. By the way, since the reticular activating system is located dorsally in the pons, ventral pontine lesions, which can still be devastating, do not cause coma. What's the name of the syndrome in which patients have severe motor disability and appear to be unresponsive but actually are cognitively intact? That's right, locked-in syndrome. Damage to the corticospinal and corticobulbar pathways results in total paralysis, save eye movements. So to cause disordered consciousness, a lesion must be in one of 4 locations. So how do you narrow it down?
An ancestor of mine maintained that if you eliminate the impossible, whatever remains, however improbable, must be the truth.
So this is where brainstem reflexes come in. You know how eyes are the window to the soul? Well, pupils are the window to the brain. Remember the parasympathetic response to a light shining in the eye? Cranial nerve 2 in and cranial nerve 3 out, with a brief stop in the midbrain pretectical nuclei. So, if your comatose patient has a blown pupil, then chances are the ipsilateral midbrain is affected. Next is the vestibulo-ocular reflex. This is elicited by the oculocephalic maneuver, you might call it the doll's eye maneuver, or ice water injections into an ear, also called cold calorics. This uses the vestibular nuclei, which are in the medulla, to activate horizontal eye movements from the pons. Before we get further though, if you learn the mnemonic cows, cold opposite, warm same, forget it. Put it out of your brain immediately. It doesn't help you at all. You might remember that the vestibular nuclei control the pontine paramedian reticular formation in a contralateral fashion, just like the frontal lobe. So if you infuse ice water into the right ear, that inhibits the signal to the right cranial nerve 8 and vestibular nucleus. The left vestibular nucleus is now hyperactive relative to the right, so it activates the right PPRF, pushing the eyes towards the right, the side of the ear where ice water was injected. In a conscious person, the eyes will deviate towards the ear in which cold water is injected, but then the frontal eye fields will cause a corrective saccade back to midline. In a comatose patient, there won't be a corrective saccade since the frontal eye fields won't be active, so the eyes will remain deviated towards the ear in which cold water was injected. The pons can additionally be tested via the corneal reflex. The corneal touch is sensed with cranial nerve 5, and the eyes respond with a blink via cranial nerve 7. Nuclei for both of those are in the pons. Cough and gag reflexes are activated through the nucleus ambiguus and the nucleus of the solitary tract. Both of those are in the medulla. Why in the world are we testing the medulla? We just said that the ascending reticular activating system starts in the pons, above the medulla. Well, you're going to learn that mass lesions can cause damage in a progressive fashion, and absent medullary reflexes can suggest extensive destruction. So by the time lesions reach the medulla, the patient is typically intubated as pictured here. So we're going to use a suction cannula in the intratracheal tube to test the cough reflex. Finally, we're moving from brainstem reflexes to see motor responses. We're going to resort to painful stimuli to try to elicit meaningful responses from unconscious patients. There's a lot of ways you can do this: sternal rub, applying pressure to the supraorbital ridge, nail bed pressure, or pressure over the temporomandibular joint. It's the only way to get a decent exam. Just don't do it without explaining why you're doing it to any family at bedside. So it's one thing to observe a response, but how do you describe it when you're presenting a case? Well, normal people are awake, oriented, and following commands. One step below that is disorientation or aphasia. Drowsy patients are lethargic but arousable to stimulation like voice or light touch. Obtunded patients need more vigorous stimulation to arouse them. And stuporous patients only localize to deep pain, basically reach out to push away the painful stimulus. Drowsy, obtunded, and stuporous patients all exhibit meaningful responses. Once meaningful responses are absent, a patient is described as comatose and either withdraws reflexively, exhibits abnormal posturing, or doesn't respond to pain at all. Really, only comatose here has a specific meaning. The other terms can be pretty vague and often pretty inconsistent between different providers. I think it's more important for you to describe what the actual response is from the patient to the stimulus you're applying. Let's see how this plays out in a hypothetical situation. Say a patient develops a mass lesion, hematoma, tumor, cerebral edema, etc. Here we've got a subdural hematoma. That mass lesion will exert mass effect on the brain, causing different parts to herniate. The medial frontal lobe can herniate under the falx cerebri, which separates the two hemispheres. Diencephalon can herniate centrally downward into the midbrain. Medial temporal lobe, the uncus, can herniate onto the midbrain. And finally, the cerebellar tonsils can herniate through the foramen magnum. So what signs do you expect to see in central herniation? Let's start with breathing. What drives breathing? It's really to blow off CO2 more than in taking in oxygen. So the hypothalamus is our best chemoreceptor. But when the hypothalamus is damaged, we have to rely on the slower secondary chemoreceptors in the fourth ventricle to sense the rising CO2. So, patients with hypothalamic damage hold their breath until the CO2 rises enough to trigger ventilation. They then breathe really fast and hyperventilate to blow off that CO2. But then when the CO2 declines, they lose that drive again and go back to apnea. That bouncing back between hyperventilation and periods of apnea is Cheyne-Stokes breathing. You can see it in other diseases, but it's also characteristic of central herniation. So here's me Cheyne-Stoking. Okay, that's enough. I'm getting lightheaded. The hypothalamus is also where sympathetics originate. So what do the sympathetics do to the pupils? They dilate them. So if the sympathetics are damaged, the pupils will be small, but still reactive. These are so-called diencephalic pupils. Unfortunately, many toxic metabolic derangements can also result in the same pupil responses, so this isn't specific. Aside from the pupils, brainstem reflexes will be normal in central herniation. And what about the motor response? Patients may become paratonic. This means that they feel like they're resisting your exam. Or they can have flaccid or flexor decorticate posturing with upgoing plantars when there's sufficient damage to the corticospinal tracts above the red nucleus. Central herniation is symmetric, but uncal herniation is asymmetric. Breathing can be normal, or you can see Cheyne-Stokes respirations. The earliest and most subtle sign of uncal herniation is the dilation of the ipsilateral pupil. Midbrain damage progresses to involve the cranial nerve 3 nucleus, and the ipsilateral eye develops medial rectus weakness. So in this image, the left eye with the dilated pupil does not adduct with vestibulo-ocular reflex testing. So you've got the left eye is down and out with a blown pupil. Got it? Motor responses are similar to central herniation, except abnormalities are contralateral. So in this scenario, left uncal herniation causes a left blown pupil and flexor posturing on the right. Make sense? So why do we spend so much time identifying central and uncal herniation syndromes? These are the herniation stages where you can still intervene with reasonable success. If you miss this window, herniation can progress to the more serious tonsillar phase. Breathing becomes apneustic with long respiratory pauses, or ataxic, which is very irregular. The pupils become fixed and unresponsive. The brainstem reflexes disappear, and motor responses progress from extensor decerebrate posturing, which the lesions below the red nucleus, to quadriplegia or even clonus. So now that we understand some of the herniation syndromes and the associated neurologic signs, let's get back to our case. Our patient has minimal withdrawal to pain on the right side. The right pupil is larger than the left, and the right eye is down and out. Lower brainstem reflexes are present, but there's extensor posturing on the left side. So, is our patient's brain herniating? If so, what type of herniation? I hope you said uncal herniation, because that's absolutely right. So what do we do next? So the presence of a herniation syndrome usually suggests there's an intracranial pressure crisis. So let's learn how to manage that. By the way, you may have noticed we haven't even done any imaging or considered the cause of the patient's herniation. Remember, it's a neurologic emergency. It's called a crisis for a reason. We're treating first, we'll ask questions later. The container illustrated here represents the human skull. I know, it's a box, but work with me. The 4 major compartments are the brain, the blood in the arteries, which is really driven by the brain's metabolism, the blood in the veins, and the cerebrospinal fluid. These boxes are not drawn to scale. The brain takes up most of the space. The Monroe-Kelly doctrine supposes that the sum of those 4 compartments is always equal. After all, your skull can't suddenly get bigger or smaller. Let's add a mass lesion. So now if there's more volume in the skull, then the pressure has to go up. So initially, venous blood and cerebrospinal fluid are pushed out of the skull to compensate for the new mass. But eventually, as the mass effect worsens, you've exhausted these mechanisms of compensation, and the brain gets squished.
Houston, we have a problem.
So let's help our patient's brain and lower the ICP. So first, we're going to raise the head of the bed greater than 30 degrees, and we're going to turn the head to mid position to improve venous return. These might seem like small things, but I will tell you, it has a huge effect on a patient's ICP. You'd be surprised how much the ICP can go up when one of the neck veins are compressed when the head's turned to one side. Our patient is already intubated, so we can start hyperventilating her. So within minutes, CO2 is blown off, and the low CO2 causes vasoconstriction in the cerebral vessels. Less blood in the arteries means less volume in the brain, which means less intracranial pressure. This effect is rapid, but short-lived, so we've got to think of other things to do as well. We also should be careful of rebound hypercarbia when we stop hyperventilating the patient. If the patient is coughing and fighting the ventilator or otherwise agitated, the patient is doing a lot of Valsalva, and that's increasing ICP as well. Sedation can achieve a calm and motionless state, which can help with venous return, but also it can reduce cerebral metabolism, and that's going to reduce the need for cerebral blood flow, reducing the amount of blood in the arteries and reducing the volume inside the skull. Next, we can address cerebral edema with either osmotherapy, mannitol or hypertonic saline, or glucocorticoids. So let's talk about edema. Fluid movement in and out of the brain parenchyma is controlled by the neurovascular unit. I'm telling you, the neurovascular unit is like the fundamental particle of our world of neurocritical care. You probably know it by another name, the blood-brain barrier. Here it is. They're astrocyte foot processes that are wrapped around the capillary endothelial cells, and they're all connected by tight junctions. This is a very secure barrier. But what happens when this barrier breaks down? So if these tight junctions give way, the water's coming out of the capillaries through the tight junctions and into the brain parenchyma. And that causes vasogenic cerebral edema. The blood-brain barrier is disrupted when infections, also tumors, cause inflammation. So this vasogenic cerebral edema is really responsive to anti-inflammatory agents like glucocorticoids. How is this situation different? Here, everything is swollen. The fluid regulation is disturbed, and the excess fluid is inside the cells, not in the interstitium. This classically happens with ischemia, where neurons and astrocytes can no longer drive their sodium-potassium pumps to maintain their electrochemical gradients. Water rushes into the cell. In this situation, we need to dehydrate these cells. And we turn to the superheroes of the neuro-ICU, mannitol and hypertonic saline. In an emergency situation like ours, when you don't necessarily know which type of edema you're dealing with, osmotherapy is always your first choice. So the Monroe-Kelly doctrine tells us that all these compartments have to add up to a fixed volume. Well, let's think outside the box, crack open the skull. For some of these pathologies, surgical intervention may be appropriate. So we're really talking about two procedures. One is a craniotomy, so removal of a piece of skull to decompress the brain under pressure and access a mass lesion for resection. Like you want to take out a tumor or take out a hematoma and decompress the brain that way. And an external ventricular drain, which as the name suggests diverts CSF externally from a ventricle. So here we're taking CSF out and reducing that compartment. An EVD can be both a pressure monitor and a treatment, especially in cases of obstructive hydrocephalus. When all of these interventions fail, you really have to resort to some desperate measures. The two options remaining are therapeutic hypothermia and/or induced coma with pentobarbital. These both greatly reduce cerebral metabolism and thus the need for cerebral blood flow, but they have a lot of other problems, and you're not going to see them outside of an ICU. I'll tell you though, if my back's up against the wall and I've got nothing else to turn to, I'm going to throw the kitchen sink at my patients, and that includes these therapies. So let's get back to our patient. We elevated the head of bed, we hyperventilated her, and we gave her hyperosmolar therapy. After that, we started seeing signs that the herniation was improving. Her anisocoria improved, and now she's got more meaningful motor responses on the right side. Whew. I am breathing a sigh of relief now because we have a moment to start thinking about what else we can do for our patient. So, what is her pathology? So let's talk about the differential diagnosis of coma. The list of disorders is long enough to fill a whole book. In fact, there is a book, Plum and Posner's Diagnosis of Stupor and Coma, which is a real classic of neurology. In this section, I'll give you a sampling of some of the common and testable conditions that cause coma. It is a long list, so now is probably a good time to pause this talk and take a coffee break. Are you ready? Caffeinated? Let's move to the next section. So here are the usual suspects of severe encephalopathy, including coma. We've got vascular, infectious, hereditary, traumatic, neoplastic, toxic metabolic, and immune-mediated. Prion disease is really hard to categorize. It behaves like an infection, but it can be hereditary too. I'm shoving in the hereditary box for now. So first up, vascular. Vascular pathologies include ischemic and hemorrhagic strokes, and also hemodynamic issues. So basilar artery occlusion, massive hemispheric and cerebellar infarction, and venous sinus thrombosis are the usual ischemic suspects. Thalamic hemorrhages, large hemispheric hematomas with mass effect, and subarachnoid hemorrhages can all cause coma. Posterior reversible encephalopathy syndrome even has encephalopathy in the name, so you know it's important. Global anoxic injury, such as in the setting of cardiac arrest, rounds out this list. Here you're looking at an axial head CT slice. By convention, when we look at head imaging, the patient's left is on the right-hand side of the screen. It's as if we're looking from the patient's feet up towards the head of the bed. This slice is at the level of the pons. You see the bright spot? That's the basilar artery, and it's hyperdense. That's concerning for a thrombus. So after seeing that bright spot, we got a CT angiogram of the head. Here, the two vertebral arteries are labeled. Look at that tracing though. This is where the basilar artery is supposed to be, but isn't. The clinical presentation of basilar artery thrombosis, it can be pretty variable, but it usually involves acute weakness, brainstem signs, eye movement abnormalities, ataxia, dysarthria, dysphagia. Oh, and I forgot, coma. You remember why we're doing this talk? If you want more information on this, watch the stroke talk. It's definitely a diagnosis you don't want to ever miss. Now, you try reading this image. I'll give you a minute. You probably said that these are non-contrast head CT axial slices, one through the midbrain and the other at the basal ganglia level. And you probably noticed that all the sulci are hyperdense. The sulci are supposed to be filled with CSF, and that should be hypodense on CT. So hyperdensity means blood in the subarachnoid space. So this is a classic high-grade subarachnoid hemorrhage. There's also some intraventricular hemorrhage that's marked by the white arrows. So tell me, how is this patient going to present? That's right, worst headache of life and meningeal signs. In the emergency room, though, every patient with a headache is having their worst headache of their life. After all, that's why they're in the ED. So we're often leaning more on imaging and LPs to really rule out this diagnosis. Here's another example of a coma-producing lesion. Imagine a patient with a history of hypertension who then develops sudden gait instability, nausea, vomiting, and might even have fallen to the ground, followed by rapidly progressive coma. Again, two axial head CT slices, one through the pons, and other at the level of the temporal horns of the lateral ventricles. So you can see a large right cerebellar hematoma with some intraventricular extension of blood to the fourth ventricle. So when blood enters the CSF space, it clots, plugs up the flow of CSF, and causes obstructive hydrocephalus. One of the early radiographic signs of obstructive hydrocephalus is prominent temporal horns of the lateral ventricles as pictured on the right. Normally, temporal horns should be slit-like. These are dilated. That's a clue that this patient has hydrocephalus. Now look at this axial head CT slice through the basal ganglia. What's abnormal? That's right, the basal ganglia and the cortical ribbon appear to be symmetrically hypodense. So imagine a brain suffers a global anoxic ischemic injury, such as during cardiac arrest or drowning. So which areas of the brain are most sensitive to the lack of oxygen? Which areas do you expect to be damaged?
I'm a doctor, not a database.
Well, obviously it's going to be the parts that require the most energy to run. That includes the basal ganglia, the hippocampus, layer 4 of the cortex, especially your visual cortex, and the Purkinje cells of the cerebellum. These are the big energy hogs of the brain, and those are the ones that are most vulnerable to any lack of oxygen. So this is the pattern of injury that you're seeing here on the CT scan, aside from the cerebellum. Now, if you do the more sensitive diffusion-weighted MR sequence, you can see diffuse cortical ischemia even better. See how the cortex is bright on this MRI? That tells us that it's ischemic. Now, this patient presented with hypertensive crisis with a systolic in the 220s, a worsening headache, bilateral vision loss, seizures, and lethargy. This is posterior reversible encephalopathy syndrome. So you probably know the old Voltaire quote that the Holy Roman Empire was neither Holy Roman nor an empire. Yeah, of course you do, because everyone loves French philosophers. Anyway, same thing here. It's not always posterior or reversible. In the setting of highly elevated blood pressure, it can be part of hypertensive emergency. It's probably also the same entity as eclampsia in the obstetric patient. So hydrostatic pressure and/or increased permeability of the blood-brain barrier are the cause. Certain immunosuppressants, like tacrolimus and cyclosporin given to renal transplant patients, can also cause this disease. And you can see that right here. These are axial FLAIR MR images. FLAIR is a T2 sequence with the CSF digitally subtracted to better highlight abnormalities. The slice on the left is through the basal ganglia, and the slice on the right is higher up in the brain. On both of these slices, you can see extensive hyperintensities that correspond to vasogenic edema in the white matter, predominantly in the occipital and parietal lobes. So hence, posterior encephalopathy syndrome. So this is a good example of vasogenic edema that's not caused by an infection or a tumor. We usually treat it by lowering the blood pressure and/or removing the offending agent. Now let's take a look at a few infections. So typical infectious causes of coma include acute meningitis and encephalitis, that can be bacterial, viral, or fungal, brain abscess, and progressive multifocal encephalopathy due to JC virus infection. Here is a T1 MRI axial slice with contrast. What's abnormal? Well, the meninges are abnormally enhancing. This is a nice example of acute bacterial meningitis. The patient here typically develops headache, fever, stiff neck, and alteration of mental status, along with seizures. A small number of cases, especially children, develop severe vasogenic edema and elevated intracranial pressure, which is translated to the optic nerve, causing papilledema. Meningitis can be caused by a variety of organisms, including bacteria, fungi, and viruses. The most common bugs are Streptococcus pneumoniae, Neisseria meningitidis, and good old enteroviruses. Add Aspergillus and Listeria to this list in immunosuppressed patients. Invasion of the meninges is usually done via the bloodstream, so don't forget to check blood cultures to identify the organism. Meningitis can also develop if there's a communication between the meninges and the surface, such as a CSF fistula. Think of patients with an open head injury or just post-brain surgery. Obviously, in our neuro ICU, this is one of these things we always look out for. Lumbar puncture is the key to diagnosis, but if there's one thing I want you to take away from this, you should not delay starting antibiotics for the LP. Typically, cover the patient with vancomycin and ceftriaxone, adding ampicillin in an immunosuppressed patient. You should also consider adding dexamethasone. This can really help with severe cerebral edema. Bacteria, fungi, and parasites all form localized infections, but viruses are usually widespread and bilateral and cause coma more often. So here's an example of encephalitis that's caused by herpes simplex type 1 virus. This is by far the most common viral encephalitis. This patient developed progressive personality changes, memory difficulties, and seizures 2 weeks prior to presentation. Here are axial T2 images that both show hyperintensity in the frontal and temporal lobes, as well as the insula. These are the areas where infection usually begins and where you expect lesions to cause the symptoms I just described. The CSF usually shows elevated protein with lymphocytic pleocytosis, and HSV PCR is diagnostic. EEG can also be helpful in showing epileptiform activity coming from the damaged temporal lobes. As with bacterial meningitis, early treatment is key, so don't delay starting acyclovir for the LP. If an infection can't be eradicated by the body, it's walled off in an abscess. Just like you shove all of your junk in the closet and don't want to look at it anymore, that's what the body does. And you can get abscesses in the brain just like anywhere else. Abscess symptoms are really the same as any other mass lesion, like a tumor or a hematoma, except they progress a lot more rapidly with headaches and seizures. You don't always get fever, so you should really try to elicit a history of a known infection source, like an infected heart valve or a dental abscess or immunosuppression. So here's an imaging example. This first image is an MRI. It's a T1 sequence with contrast. It's an axial cut, and it's at the level of the basal ganglia. So you can see a medical student favorite here, ring-enhancing lesion. There's nothing particularly magical or pathognomonic about ring enhancement. It's just a descriptor. It just indicates that there's an area of blood-brain barrier disruption surrounding the mass. Many disorders can have the same appearance, so we need to look at other MRI sequences. In the middle, here's a T2 axial image. The abscess is confined to the temporal lobe, but look at the massive amount of subcortical vasogenic cerebral edema. Abscesses are highly irritating to the brain, and they often generate more edema than a tumor of the same size. You can imagine all that junk that's walled off in your closet just starts spilling out. And finally, on the right is a DWI sequence, and you see bright diffusion restriction. Diffusion-weighted imaging highlights areas of viscous fluid that's filled with cellular debris, bacteria, and inflammatory cells. You might remember from the stroke talk that diffusion restriction is really our gold standard to diagnose stroke, but not all things that restrict diffusion are strokes. Here we have a mass lesion that's not really obeying any kind of vascular territory and is accompanied by a huge amount of vasogenic edema. How do you treat it? Well, start antibiotics, and just like you have a pocket of pus anywhere else in your body, drain it. Traumatic injury is next. There's usually no mystery about the diagnosis here. Post-traumatic coma is usually caused by extraaxial hemorrhages, such as an epidural hemorrhage or a subdural hemorrhage, but also by hemorrhagic brain contusions, diffuse axonal injury, brain edema, and fat embolism with long bone fractures. So let's take a look at some examples. Here's a non-contrast CT, axial cut, at the level of the basal ganglia. So what are the abnormalities here? Well, there's a big lens-shaped hyperdensity outside the brain in the epidural space.
Sounds like a subdural hematoma to me.
Oh, it does it? Well, it's not your job to diagnose.
But I thought...
You thought, just go! 3 years of nursery school and you think you know it all, but you're still wet behind the ears. It's not a subdural hematoma, it's epidural. Ha!
Why am I saying it's outside the brain and in the epidural space? Well, you probably remember that the epidural space respects the suture lines, and this lens shape doesn't pass beyond them. This bleed was likely caused by a tear of the middle meningeal artery, which was damaged when the temporal bone fracture crossed the middle meningeal groove. On the right, the CT image has been adjusted to highlight the bone. You can see there's a fracture in the skull overlying the hematoma. Classically, these patients start with a headache post-trauma and progress rapidly to coma over hours because of the rising mass effect of the expanding hematoma. Only about 1/5 actually have the classic history, though, of this traumatic loss of consciousness followed by the lucid interval. Take a look at this non-contrast head CT axial slice through the midbrain. This patient was taking rivaroxaban, which is a direct factor 10A inhibitor, for the treatment of deep venous thrombosis. She slipped and fell in the kitchen, hitting her head. She was comatose on arrival. Your first clue of something being wrong is the absence of any fluid-filled hypodense CSF spaces around the midbrain. Usually there's a nice moat around the midbrain. Here, there's no space at all. It's squished up right against the rest of the brain. Look around for a reason. Well, do you see those two crescent-shaped hyperdensities outside the temporal lobes that are compressing the brain? These are clearly spreading out along the brain, crossing the suture lines. So it's not an epidural hematoma, it's a subdural hematoma. This is a classic example of an acute subdural hematoma that was probably worsened by anticoagulant use in this patient. Finally, diffuse axonal injury is an important mechanism of traumatic coma, especially in patients who don't have an overt, large traumatic lesion. Diffuse axonal injury is a type of traumatic brain injury where acceleration and deceleration leads to shearing forces on the white matter tracts of the brain, causing damage to the axons. So the first three images here are axial flare MRI sequences ascending from the level of the basal ganglia. You see multifocal white matter hyperintensities, which by themselves are really not specific, except here you see them in the corpus callosum and also scattered in the periventricular and frontal areas. Combined with the history of a high-speed motor vehicle accident, these hyperintensities are very suggestive of diffuse axonal injury. To really make the diagnosis, though, we need to see blood. So the last two images are a gradient echo GRE axial cut. GRE is a specific sequence that's tuned to pick up hemosiderin, which is to say blood. And here you see several areas of susceptibility, dark spots, that correspond to microhemorrhages in the white matter. Next up, tumors. Neoplastic lesions causing coma are generally either massive intracerebral tumors like primary gliomas or metastases, leptomeningeal disease like lymphomas, dural-based tumors with mass effect such as meningiomas, or pituitary tumors. That last group can cause altered mental status not by mass effect, but its effect on the endocrine system. Here is axial and sagittal T1 sequences, both with contrast, as well as an axial T2 sequence on the right. You can see the abnormality from across the room. There's a large, ugly, enhancing, bulky mass involving the corpus callosum and surrounded by cerebral edema, that bright hyperintensity you see on the T2 sequence. This patient has a glioblastoma multiforme, the highest grade of primary CNS glioma. Gliomas typically invade the substance of the brain and then create mass lesions. They have bulk. They push everything out of the way. As they get bigger, they outgrow their blood supply and develop areas of necrosis or hemorrhage inside. Now here's a similar MRI. We're looking at the axial T2. Do you see the vast amount of vasogenic edema? I say vasogenic because the cortical ribbon doesn't seem to be affected. The hyperintensity respects the boundaries of the white matter and gray matter. This edema even seems to be involving the corpus callosum. So what do you think this tumor is? Another glioblastoma?
Yes! And no.
Then what are you saying?
I'm saying no. But I'm leaning towards yes.
Then you're saying yes?
No.
Then it's no.
Not necessarily.
You sound dubious.
No, I'm positive.
Of what?
My theory!
And that would be?
The theory of yes or no.
Well, here's a T1 axial and coronal slice with contrast to help you. So what do you see? This mass is outside the brain. This mass is based in the dura, and I say that because it has an enhancing dural tail, the region of the dura adjacent to the mass that's also enhancing. So what's the most common dural-based mass? Well, it's a meningioma. Meningiomas typically grow over the convexities along the falx or along the base of the skull at the sphenoid wing. Because these are typically slow-growing tumors and usually don't create this much mass effect acutely, coma is an unusual presentation. One exception would be a meningioma that hemorrhages within itself. More likely, meningiomas present with focal deficits by compressing the brain structures and also with seizures. The treatment here is as what you'd expect: corticosteroids to treat the edema and surgery to remove the tumor. Finally, let's take a look at an example of encephalopathy caused by extensive neoplastic invasion of the leptomeninges and also the subarachnoid space. You're looking at an axial and a sagittal T1 sequence here, both with contrast. The first image is through the pons, with the occipital lobe showing up posteriorly. The second image is just to the left of midline, and you can see the cerebellum and the occipital horn of the lateral ventricle. The brainstem would be more medial, so you don't see it. Look for the patchy enhancement that perfectly follows the sulci. This is enhancement of the subarachnoid space in the pia. The subarachnoid space surrounds the entire central nervous system. The cranial nerves travel through this subarachnoid space. So the hallmark of subarachnoid tumors is multi-level dysfunction: cranial or spinal nerves, spinal cord, brainstem, or the hemispheres. So why do you get coma? Well, number of reasons. They can be hydrocephalus from obstruction of the spinal fluid pathways, direct invasion of the brain through the pial vessels, status epilepticus, or overactive immune response to the tumor. Biopsy is the gold standard here for diagnosis. CSF cytology via lumbar puncture doesn't have a lot of sensitivity. You can do multiple high-volume lumbar punctures for CSF cytology and still not find neoplastic cells. In this case, this patient was diagnosed with meningeal lymphoma. If you're rotating through the ED and you see a comatose patient, toxic metabolic causes are probably going to be first on your mind. You could be thinking of toxidromes, drug overdoses, or drug-drug interactions. For example, serotonin syndrome from a combination of selective serotonin receptor blockers and monoamine oxidase inhibitors. You could be thinking side effects of poisons like alcohol. You could be thinking derangements of glucose. There's a reason why we check fingerstick glucose in any unresponsive patient. You could also look at electrolyte disturbances, hyponatremia, hypercalcemia, and acidosis, renal failure, uremia, hepatic failure causing hyperammonemia, and endocrine disturbances, including the adrenal glands, pituitary gland, and thyroid gland. Obviously, that's a long list, so let's look at some examples. This patient has chronic malignancy, who then developed confusion and balance issues and presented with a rapidly progressive coma with a characteristic finding of ophthalmoplegia. That means the eyes don't move. You're all experts in neuroimaging now. So what's abnormal on these coronal flare images? Well, did you see the hyperintensities in the frontal cortex, the medial thalami, and the mammillary bodies? What's the diagnosis? Yep, this is severe thiamine deficiency, otherwise known as Wernicke's encephalopathy. All these neuronal areas are deprived of thiamine to the same extent, but certain cell groups, the neurons surrounding the third ventricle, the cerebral aqueduct, and the fourth ventricle, are pathologically more sensitive to this deficiency and show the greatest amount of damage. Remember that the diencephalon is part of the reticular activating system, so hence damage to the thalamus causes coma. The oculomotor nuclei are periaqueductal. They're right next to the cerebral aqueduct. Hence, you get ophthalmoplegia. You probably already remember this. Giving glucose without thiamine can precipitate excitotoxicity in this disease and worsen the outcome. So who gets Wernicke's? Well, obviously you think alcoholics, but really anyone who's malnourished. That includes cancer patients like this one. What's the treatment? High-dose thiamine. You give it IV, high dose for several days. The nystagmus and the oculomotor paralysis can be reversed by thiamine, but oftentimes the damage to the thalamus and the mammillary bodies can't. This can cause striking memory failure and confabulation when the patients awaken. And that makes up the Korsakoff part of Wernicke-Korsakoff syndrome. Autonomic insufficiency in this disease is very common. Think orthostatic hypotension and even shock. So these patients are usually monitored in the ICU. Okay, by now you know the drill. Axial T2 and flare cuts through the lower and upper pons with bilateral temporal lobes visible as well. What do you see? Hyperintensity in the white matter of the central pons and also in the medial temporal lobes. So what's the diagnosis? This is central pontine and extrapontine myelinolysis. I put this in just to remind you that lysis of myelin doesn't have to be limited to the pons. That's why the name of this disease is now osmotic demyelination syndrome. Usually these are patients who've suffered chronic hyponatremia and then got overcorrected in the hospital. The majority of these patients become locked in, but a quarter of them can also develop impaired consciousness. Quick flashback to the start of this talk. Remember that damage to the ventral pons can cause locked-in syndrome, but the reticular activating system is located in the dorsal medial pons. So depending on where the osmotic damage is, it can cause either of these syndromes. So final example, hypoglycemic coma. This diabetic patient accidentally overdosed on insulin. There are few things more dangerous to the brain than profound, prolonged hypoglycemia. The longer it lasts, the more likely it will produce irreversible neuronal damage. Glucose is brain's fuel, and each 100 grams of brain uses 5.5 milligrams of glucose per minute. Basically, the brain consumes almost all the glucose that the liver produces. So this axial T2 image through basal ganglia shows extensive damage to the areas of the brain that need glucose the most, the cortical ribbon and the basal ganglia. And you're going to say, well, this looks exactly like the image of a patient with hypoxic ischemic encephalopathy. And you're absolutely right. The same parts of the brain that need oxygen also need glucose. Finally, let's wrap up the pathologic differential with the discussion of immune-mediated disorders. When it comes to immune-mediated comas, we're talking about autoimmune encephalitides like acute disseminated encephalomyelitis, ADEM, Bickerstaff encephalitis, neurosarcoid, and lupus cerebritis. Vasculitides like Behçet's or primary angiitis of the central nervous system are also under this category. And paraneoplastic disorders like anti-NMDA receptor encephalitis and limbic encephalitis, where an underlying malignancy triggers autoimmune damage to the CNS. A lot of itises, and I'm tired from saying all of them, but let's move to the cases. At this point, I won't call out the imaging technique or brain structures. You're on your own now. Time to channel your inner neuroradiologist. Imagine you're in a very dark room and describe what you're looking at. I'll give you one clue. This is a 6-year-old, previously healthy young boy who had a mild upper respiratory tract infection 2 weeks ago, and now comes to the emergency department with 2 days of fever, headache, slurred speech, gait instability, excessive sleeping and disorientation, and increased muscle tone throughout. Did you say that this is a T2 flare axial image with diffuse white matter hyperintensities? Yeah, I knew you would. This is a classic case of ADEM. I'm going to say ADEM because it's a lot easier to say than acute demyelinating encephalomyelitis. Patients are usually younger and develop multiple neurologic symptoms, including cognitive and behavioral changes, that's the encephalitis, over a period of several days, about 1 to 2 weeks after a febrile illness. ADEM is an example of a parainfectious encephalomyelitis. The itis here is presumably caused by a deranged, aggressive immune response to a virus or vaccination. What causes this? Well, we don't know. Usually we throw in phrases like molecular mimicry, but just imagine me waving my hands a lot right now. The CSF can show mild lymphocytic pleocytosis, usually less than 500 cells, and elevated protein, but it also may be normal. This illness is monophasic. It usually resolves with some steroids and immunosuppressants and time. It rarely recurs. So imagine you're an ED doc who's now seeing this child. What's the diagnostic challenge? Well, we really have to differentiate between the itises that are caused by viruses, requiring antiviral treatment, and the autoimmune parainfectious response, requiring immunosuppression. One clue is that patients with viral encephalitis tend to be more severely ill with higher fevers for longer periods of time, and then the autoimmune stuff tends to start when the viral illness has already passed. Next case. Here's a 25-year-old woman who presented with a 1-week history of progressive headaches, vertigo, audiovisual hallucinations, and progressed to developing coma, seizures, and myoclonus. Here are 3 FLAIR slices from the same brain. They show temporal, insular, and frontal hyperintensities, suggesting an encephalitis. MRI is not very specific in this disease, since temporal abnormalities can look like HSV infection, though without enhancement. The cortical abnormalities can look like a stroke, but without restriction of diffusion on DWI, and the white matter abnormalities can look like ADEM. It's clearly a big mimic. You get the picture. History is much more important here, and thankfully there is diagnostic testing. This is an example of NMDA receptor antibody encephalitis. Think of this cause of coma in a young woman with initially viral-like prodrome, who then goes on to develop psychiatric symptoms and eventually progresses to coma, seizures, hyperkinetic movement disorders with an abnormal involuntary jerky movements, and autonomic storming, so bouts of hypertension and tachycardia and diaphoresis. The NMDA receptor mediates glutamate, which excites neurons. So you can see all these symptoms are caused by overexcitation of neurons in the brain. Diagnosis can sometimes be difficult because, after all, you're getting young patients who are having their first bout of psychosis. It all happens about the same age. Beware of patients who don't have any personal or family history of psychiatric illness, who suddenly go on to develop psychosis, and any abnormal neurologic findings. I can tell you, I've taken care of teenagers who initially were diagnosed with schizophrenia and spent days in the psychiatric unit before going on to develop seizures and other findings that clearly pointed to a different type of disease. This paraneoplastic syndrome is often associated with ovarian teratoma or carcinoma. It's important to stick with treatment with these patients. Their treatments often were very prolonged, although after sometimes weeks or months of immune therapy, these patients can go back to a normal life, school, and work. Well, after all that detour, have you forgotten about her case? Let's get back to it. When we last left her, she was exhibiting signs of uncal herniation, which then reversed after our management. So what are we going to do next? The top 3 disorders that cause sudden coma and need to be emergently addressed are vascular, such as a basilar artery occlusion, hemorrhage, or a straight sinus thrombosis, status epilepticus, or a mass lesion, such as a neoplasm. Our patient had mass effect, so it stands to reason that hemorrhage and mass would be at the top of our early differential. Let's look for that structural lesion. What's the best initial test? That's right, a non-contrast head CT. If we were worried about a basilar artery occlusion or other vascular issue, we would get vascular imaging with a CT angiogram of the head and neck with contrast. That's less likely in this case. Here's our patient's head CT at different axial cuts in the brain. The right image is the customary view through the basal ganglia, and the left image is above that. Try to read the scan. I'll give you a minute. You can probably make out the heterogeneous right frontal hyperdensity surrounded by hypodensity. There's also a significant amount of mass effect, See how the right hemisphere is pushing over into the left side? That's called midline shift. So our patient underwent an emergency craniotomy, decompression, and evacuation of the lesion, which end up being a hemorrhagic tumor, glioblastoma multiforme in this case. Here you can see her post-op head CT. The skull has been removed on the right, so there's a small amount of air in the cavity where the tumor used to be. The mass effect is improved, and there's a small amount of hemorrhage spilled over into the lateral ventricles. Post-surgery, our patient's alertness has improved to the point we're able to extubate her. She's now arousable to voice, she's following commands. There's still persistent left-sided weakness, but she has some movement on that side. The next day, though, she was once again difficult to arouse, and the left-sided weakness became worse. Well, that's puzzling. What's going on here? Her vitals and labs are normal, and there are no sedatives that are confounding the picture. We repeated the head CT, and that was stable. Take my word for it. So the mass effect has been dealt with, and yet our patient's deficits are out of proportion to the scan. Why?
How does your modern science explain that? Can you explain that? Can you explain that?
I can't explain that. I can't explain that.
No one can explain that!
How do we figure this out, and what's the next best step in management? Well, neurologically injured brains are prone to seizures. Up to 1/3 of neurologically critically ill patients develop status epilepticus. So, we should consider treating empirically. Start antiepileptics. Then, let's make the diagnosis. Start with a spot 30-minute EEG, and then progress to a 24-hour continuous EEG to assess for seizures. Unfortunately, our hunch was right. The patient had right frontotemporal epileptiform activity, probably coming from the brain surrounding the tumor cavity, and 2 electrographic seizures were captured during a 30-minute recording. So what do we do next? This is a progression of status epilepticus management. On the left side of the screen, the patient has just started seizing, and we're just starting our initial therapies. As we move towards the right, we're going through higher tiers of therapies and interventions. We've already secured the airway, and the ABCs are stable. The first-line medications are short-acting benzodiazepines, like lorazepam or diazepam, and that would typically abort seizures early. But if these seizures continue, we move on to second-line medications, like fosphenytoin, valproic acid, phenobarbital, or levetiracetam. Now, I advocate moving directly to general anesthesia if your first-line medications fail, since it takes time to start with the second-line medications. The sooner we stop the status epilepticus, the more secondary brain damage we're going to avoid. In our case, the patient is already intubated and will need sedation anyway. So we start midazolam or propofol, which are short-acting and titratable anesthetics. We then titrate the anesthesia to stopping the seizures on the EEG. This basically acts as a reset for the injured brain. In cases where status epilepticus persists for more than 30 minutes despite therapy, at that point it's classified as malignant. I'm pretty sure you've guessed, malignant anything is not good for the brain. So just like an intracranial pressure crisis, we may proceed to higher levels of therapy, including inducing pentobarbital coma. And it goes without saying, ICU-level care and continuous EEG monitoring are musts for a patient in status. So we treated our patient with midazolam and levetiracetam, and the seizures stopped. Sadly, not all is well that ends well. Her ICU course was prolonged and very complicated, and at some point she suffered a brief cardiac arrest. CPR was started, and return of spontaneous circulation was achieved after 15 minutes. But even 72 hours later, her neurologic exam remains poor. She has no brainstem reflexes and no meaningful responses. Obviously, this is not what we wanted, and the family is understandably devastated. They want to know what's going to happen to her. That brings us to the last part of our talk, outcomes. Imagine a graph of cognitive function on the x-axis and motor function on the y-axis. So the best possible outcomes are in the top right corner, and the worst possible outcomes are in the bottom left. Full cognitive and motor recovery is what we all hope for, but few achieve after a coma. Locked-in state belongs in this first column. This is a state of preserved cognition, but severely limited motor function. Locked-in patients aren't comatose, and they can still move their eyes. Look for vertical eye movements and blinks. That's how you can communicate.
Jean-Dominique, vous avez eu une attaque. Vous êtes resté dans le coma pendant presque 3 semaines. Mais vous êtes en train de vous réveiller et tout va aller très bien. Quand je vous dis de cligner des yeux, clignez, s'il vous plaît. C'est très bien. Maintenant, essayez de dire votre nom.
Jean-Dominique Bobby.
Allez, essayez.
Je vous l'ai
Essayez
dit.
vraiment.
Quoi?
Dites-moi votre nom.
Jean-Dominique Bobby.
Ne vous en faites pas. Le processus est très lent. Mais vous retrouverez la parole.
Pardon, quoi? Vous m'entendez pas? Docteur, qu'est-ce qui se passe? Quoi, je parle pas? Ils m'entendent pas.
E, S, A, R, R. E, S, A, R, R. E, S, A, R, I, I.
Derrière le rideau de toile mitée, une clarté laiteuse annonce l'approche du petit matin. J'ai mal au talon, la tête comme une enclume, et une sorte de scaphandre qui m'enserre tout le corps. Ma tâche consiste maintenant à rédiger les carnets de voyage immobiles d'un naufragé échoué sur les rives de la solitude.
The next column is moderate to severe cognitive or motor disability. The important distinction here is that the patient still has reliable functional communication. They're following commands and making at least some of their wishes known. On the left side of the dotted line, reliable functional communication is absent, and these patients are said to be in a minimally conscious state. Basically, this is someone with a severe alteration of consciousness. They spend the majority of their time unresponsive, but they can show meaningful awareness of self or environment by attending to loved ones, by looking at them. They may attempt purposeful movements, and so on. Next step down is persistent vegetative state. Patients have sleep-wake cycles, but show no meaningful awareness or interaction. Persistent refers to passage of time and can be diagnosed at least 1 month after brain injury. Of course, for patients in this state, outcomes for meaningful neurologic recovery are generally poor. However, because a subset of patients in the persistent vegetative state do end up recovering higher levels of consciousness, this term is falling out of favor, and we're preferring to call it unresponsive wakefulness. Finally, the most dismal outcome is death, brain death in this case. That's absence of brain activity, including brainstem function. We'll talk about the criteria for diagnosing brain death in a moment. There's a lot we don't understand about the injured brain, and making a prognosis can be very difficult. Age, baseline function, and the patient's neurologic exam are arguably the best prognostic factors. So we would be very optimistic about a meaningful long-term neurologic recovery for a young, healthy woman who suffers a coma because of severe traumatic brain injury after a motor vehicle accident, but she is now awake and following some commands. The cause of coma is also important. The best prognostication data we have is for cardiac arrest and for traumatic brain injury patients, although some data exists for outcomes post-autoimmune encephalitis, such as NMDA receptor encephalitis. I mentioned that it's important to be aggressive with treatment for these patients because outcomes can be quite good even after months of treatment. Neuroimaging can be helpful. Earlier in this talk, we saw examples of diffuse anoxic and hypoglycemic injury on MRI, portending bad outcomes. But ultimately, these are just pictures. Never make a prognosis based on a scan alone. In a comatose patient without meaningful neurologic responses, EEG with absent normal brain reactivity may serve to confirm poor outcome, but it doesn't always reliably predict the extent of future recovery. Serum biomarkers like neuron-specific enolase have been used as another confirmation of poor outcome after cardiac arrest. The use of these biomarkers, though, is still being studied. Other important predictors of poor outcomes are the duration of coma and other comorbid conditions. Obviously, someone who's been in a coma for 2 months has a poor outcome than someone who's only had a coma for several days. And a person who's in a coma due to metastatic cancer has a poorer outcome than someone with traumatic brain injury but otherwise healthy. In general, our tests are better able to tell us the patients who do poorly than predict the patients who are going to recover. The important point here is that there are no shortcuts to prognostication. Every case is unique. In our case, you may remember that things are pretty dire. The brainstem reflexes were absent in our patient, and she doesn't have any response to pain. We're really worried that she may be brain dead. How do we go about declaring this? Brain death is death, but it's not as easy to understand as cardiopulmonary death. You can feel the heartbeat, but it's a lot more difficult to figure out whether the brain is still working. So let's go through the process by which we establish brain death. First, we need to establish that there's an irreversible cause of coma. Neuroimaging can be very helpful here. Cardiac arrest, basal artery thrombosis, large hemorrhage, all of those qualify. If you don't know the cause of coma, you can't establish brain death. Next, exclude confounding factors. There can't be any CNS depressant drugs. The patient can't be paralyzed chemically. The patient can't be hypothermic or very hypotensive. And the patient can't have any major metabolic derangements. All of these things can cloud the neurologic exam and give the impression of a brain-dead patient. Next, you need clinical evidence of loss of brainstem function. The pupils must be fixed and unreactive to light. There must be no oculocephalic and oculovestibular reflexes, no corneals, no cough or gag reflexes. There can be no meaningful motor responses present, although reflexes like upgoing plantars or triple flexion are allowed. And the patient must not exhibit any spontaneous breathing. The patient must be completely dependent on the ventilator for breaths. The final element of brain death testing is to establish that there is no spontaneous respiratory drive off of the ventilator. That's called an apnea test. That's done by pre-oxygenating the patient and establishing a ventilatory rate to normalize the CO2 as much as possible. How do we know it's normal? We take a blood gas. Next, we disconnect the ventilator for 8 to 10 minutes. We allow the CO2 to rise above 60 or a 20 millimeter increase above the baseline. Both of these should induce respiration in someone who has an intact respiratory center in the medulla. If the patient becomes unstable during the apnea test, the patient becomes hypotensive or desaturates, we have to abort the test and reconnect the ventilator. In this case, we may rely on ancillary tests to help complete the picture of brain death. These tests aren't confirmatory tests. You can't do these tests in absence of meeting the other criteria for brain death. Ancillary tests in general look for brain death in one of two ways. Either looking for absent cerebral blood flow or absent electrical brain activity. Examples of ancillary tests include nuclear SPECT imaging, transcranial Dopplers, a cerebral angiogram, or EEG.
Thanks, Ram. Congrats, you made it. Now let's briefly discuss the entire algorithm. Say you have a patient with an acute confusional state. This could be disorientation, aphasia, or lethargy. History is still key. A good beginning would be to find out the time last known at baseline, details of event onset, comorbid conditions, medications and toxic exposures, and previous such episodes. Next, is the patient presenting within or outside of a 24-hour window from last known at baseline? Within 24 hours? Well, consider activating a stroke code, especially when you see focal neurological deficits. Vascular pathologies are a common and treatable cause of acute coma, especially with focal deficits. Once you activate the stroke code, you'll go down a rapid stroke assessment pathway, which I reviewed in the stroke talk. Next, initial stabilization. We are talking about airway, breathing, circulation, the ABCs. A common resuscitation process would include a large bore IV, or preferably 2, a cardiac monitor, oxygen via face mask, and labs including basic panel, complete blood count, fingerstick glucose, liver function tests with ammonia level, thyroid function tests, and drug levels where appropriate. When sepsis is suspected, blood cultures and lactate are also checked. And in trauma patients, we should immobilize the C-spine. If ABCs are unstable, the patient would need intubation and hemodynamic support. But once ABCs are stable, in an acutely altered patient without focal neurologic deficits, toxic and metabolic etiologies are by far the most common cause. So we should consider issues like electrolyte disturbances, especially sodium and calcium, sepsis, vitamin deficiencies, especially thiamine, and poisonings and toxidromes. If the cause of encephalopathy is known, then we can address it at this point. We can use toxin-absorbing activated charcoal and induce vomiting within 2 hours of ingestion. If thiamine deficiency is suspected, you need to treat with IV thiamine. For significant benzodiazepine overdose, there's flumazenil, but consider that carefully because it can induce withdrawal seizures. For opioid overdose, there is naloxone, which can be given intravenously or sprayed into the nose. Next, we need to move on to a rapid neurologic evaluation. We are looking for localizing or focal findings to help us identify a structural lesion, but also we check for meningeal signs and observe for abnormal involuntary movements such as myoclonus. That last one is to help with pathological differential. These movements can suggest seizure, serotonin syndrome, or NMDA receptor encephalitis. Our coma exam essentially has 4 components: respirations, pupils, brainstem reflexes, and motor responses. Next, other signs of elevated intracranial pressure? Yes? Then proceed with emergent ICP management. Head position optimization, hyperventilation, sedation where appropriate, cerebral edema management, surgical intervention, and so on. Once the intracranial pressure crisis has been addressed, we need to consider this short but dangerous differential, especially when patient has focal neurologic deficits or your examination is suboptimal. Vascular lesions, such as basilar artery occlusion, venous sinus thrombosis, and hemorrhage. Mass lesion, which by the way can be neoplastic or infectious, like a brain abscess. And status epilepticus. First things first, assess for a structural lesion. We start with a STAT non-contrast head CT. We should also get an emergent vascular study, such as a CT angiogram of the head and neck with contrast, in patients with concern for vascular pathology, which is basically everyone within 24 hours of abrupt onset of symptoms, especially when they present with focal deficits. In fact, CTAs are a part of our stroke code protocol. If we identify a hemorrhage, then we treat according to the hemorrhage protocol outlined in your stroke talk. For hemorrhages and mass lesions with mass effect, we can consider urgent surgical intervention. basilar artery thrombosis may be treated with thrombolytics and thrombectomy where appropriate. If at this point there's no obvious structural lesion, we can consider an urgent MRI of the brain with and without contrast to look for entities like completed stroke without an occluded vessel, encephalitis changes, and press. But MRI takes a considerable effort, especially in a thrashing, disoriented, or intubated patient, so it's usually delayed until later in the algorithm. Now, say there's no mass lesion or basilar artery thrombosis. At this point, we should consider cerebral venous sinus thrombosis of straight sinus, for example. To diagnose that, we will likely check a rapid CT venogram with contrast. We can also use an MR venogram, but as I mentioned, it's more difficult to get in the ED. If thrombosis is confirmed, we consider anticoagulation. Imagine all of your imaging is negative. Now let's assess for status epilepticus. We can consider treating empirically, according to the status epilepticus protocol, while getting an EEG. Start with a spot 30-minute EEG and progress to 24-hour EEG monitoring as needed. Let's say all of our workup has been unrevealing thus far. Well, now we need to cast a wider net. This is where we consider vascular and traumatic pathologies, like press, anoxic ischemic injury, diffuse axonal injury, and fat embolism, infectious and inflammatory pathologies, like meningitis, herpes encephalitis, brain abscess, ADEM, vasculitis, and paraneoplastic encephalitis, like NMDA receptor encephalitis or limbic encephalitis. Toxic metabolic pathologies are a giant category and include diseases like osmotic demyelination syndrome, carbon monoxide poisoning, hepatic and uremic encephalopathies, pancreatopathies, think diabetic ketoacidosis and hyperosmolar non-ketotic coma, thyroidopathies, adrenal disorders, panhypopituitarism, and drug intoxication, like serotonin syndrome and neuroleptic malignant syndrome. Obviously, this is not an exhaustive list. Hereditary category includes disorders like MELAS, mitochondrial encephalopathy with lactic acidosis and stroke-like events, say that 3 times fast, and prion disease. As we discussed before, prion disease probably belongs in its own category, but we lumped it here with hereditary disorders just to simplify things. We didn't discuss the hereditary category much in this talk because these disorders are usually rare in the adult patient. Finally, don't forget neoplastic pathologies, like leptomeningeal carcinomatosis, gliomas, metastasis, and pituitary neoplasms. If you suspect infection, consider treating empirically at this point. And finally, now's the time for lumbar puncture and the first or even repeat MRI. You may also want to call for some reinforcements: neurology consult, infectious disease consult, oncology consult, the house MD team. And repeating certain labs may not be a bad idea to help with diagnosis since disease processes do progress. That's all. Thank you for your kind attention, and we'll talk again soon.